Hello, everybody. My name is Alona Zer. I am a medical oncologist at the Rabin Medical Center and at the Tel Aviv University in Israel. I am honored and excited to be participating in the BAMO annual conference. These are my disclosures. In the next 30 minutes, we will go through the evolution and the role of comprehensive genomic profiling in non-small cell lung cancer. I will try to give some examples for the standard and out-of-the-box uses of these tests in the clinic and with briefly touching some new investigational indications. Going back a few decades, we have some pivotal studies establishing the role of chemotherapy in advanced non-small cell lung cancer. We cannot deny that chemotherapy tripled the overall survival compared to best supportive care, but the overall response rate was around 30%, median overall survival was less than a year, and this was regardless of which chemo we used. Oncology has transformed in the past decade thanks to two major scientific revolutions: immunotherapy and the identification of targetable driver oncogenes. If a decade ago, the median survival for patients with advanced non-small cell lung cancer was less than 1 year, today I can tell some of my patients that their expected survival can be counted in multiple years. Over 40% of lung adenocarcinoma harbor a targetable oncogenic driver. After the first wave of targets, including EGFR mutations, ALK and ROS1 fusions, and BRAF V600E mutation, we have now a second wave of driver oncogenes with emerging effective therapies. ALK fusion is a good example for this revolution. It is a rare alteration seen in 2 to 4% of patients with non-small cell lung cancer. With chemotherapy alone, only a small fraction of these patients will live beyond 2 years. But with ALK inhibitor, specifically from the second generation and more than 60% are still alive after 5 years, meaning it is crucial to identify the patients with this rare alteration and treat them appropriately. We have approved targeted treatments available for alterations in EGFR, ROS1, ALK, NTRK, BRAF, MET, RET, and since this month, also KRAS G12C and EGFR exon 20 insertion. We have recommended treatments for HER2, which is why the clinical guidelines strongly recommend broad molecular profiling to identify these rare driver mutations. The guidelines recommend comprehensive genomic profiling for all patients with advanced adenocarcinoma, as well as patients with advanced squamous cell carcinoma, providing they are either young, have no smoking history, or in cases with a small biopsy or mixed histology. The guidelines also recommend completion of these tests within 10 to 14 days from the biopsy. The NSCLC guidelines, as well as the NCCN guidelines, specifically encourage the use of broad next-generation sequencing rather than hotspot testing to allow wider and deeper coverage for these specific genomic alterations. But also, since every year we have a new and emerging biomarkers, for example, HER2 exon 20 insertion and KRAS G12C. There are also new biomarkers that seem to correlate with response or lack of response to immunotherapy. These are tumor mutational burden, KEAP1, STK11, and the list is growing. Turning now to testing methods and the challenges on the way. Historically, and also still today in some countries where comprehensive genomic profiling is not reimbursed, the genomic biomarkers were tested sequentially, first using few slides for age and diagnosis, then PDL1, then several slides to test EGFR using a hotspot PCR assay, and then ALK and ROS1, and the rest in another hotspot PCR. This method is slow and uses a huge amount of tumor cells, resulting in exhaustion of the block before all markers were tested. There is such improvement in testing methods today, with two revolutions being the introduction of next-generation sequencing and the introduction of RNA sequencing. Briefly, next-generation sequencing is a general name for different methods of extensive DNA sequencing in fast automated way. It relies on an automated reading ability of tens of thousands of DNA sequencing in parallel. NGS tests are different from each other by the coverage, meaning how many areas of the gene they sequence, and the depth, meaning how many times each segment of the gene is being sequenced, making the results more reliable. The tests also different from each other by the ability to sequence RNA. This is an illustration to show the difference between hotspot approach, where you have to know which spot of the gene needs to be tested, whereas in comprehensive genomic profiling, mutations in other spots on the gene of interest would be discovered, as well as much larger range of genes. Another forte of NGS is the RNA component. When looking for fusion, this is especially important because in many fusions, the partner is unknown. Even after deciding on the type of test, many barriers still exist in our race to get the test results. First, lack of tissue, which is a problem in as many as 25% of patients diagnosed with non-small cell lung cancer based on a biopsy. A second barrier is the turnaround time from diagnosis to result, which include ordering the test, preparing the tissue, sometimes sending it to another lab, sequencing, and interpreting the results. I'm not going into the cost issue, although the costs are dropping, but still it's a very expensive test. And I'm not going into the communication issues, which we suffer a lot from. Who will order the test? Is it the respirologist? Is it the pathologist? Is it the oncologist? All of these are prominent challenges. To show you how complicated it is, I brought some numbers from Israel, where the turnaround time from ordering the test to receiving the results is around 23 days. This long TAT, turnaround time, could also contribute to the delay from diagnosis to treatment of lung cancer, which is in Israel more than 2 months. It can also correlate with the sad statistics in lung cancer around the world, that 20 to 30% of patients with advanced non-small cell lung cancer die before receiving any treatment. This is where liquid biopsy comes in practice. It means isolating tumor cell-free DNA in blood and performing NGS on it. We use the test either on diagnosis in patients with lung cancer when the tissue is not enough for NGS, and this is supported by the ISLAC guidelines, or in patients with oncogenic driver who progress on TKI to identify the resistant mechanism. And here the only standard example is the use of liquid biopsy to identify EGFR T790M. But we're finding more and more actionable alteration on resistance as well. Let me show you some cases where comprehensive genomic profiling changes the management of patients in the clinic. Our first patient is a 56-year-old female, never smoker, who was investigated in the community for chest and musculoskeletal pain. Eventually, a CT of the thorax showed a left lung mass. She had a biopsy from the left lung, showing poorly differentiated carcinoma with the following biomarkers suggesting squamous cell carcinoma. A PET scan showed multiple bone metastases, adrenal metastases, retroperitoneal metastases, and soft tissue as well. She had palliative radiotherapy for painful skeletal metastases, and tissue was sent for molecular analysis, but the tissue was exhausted, and we were able to get only results of a hotspot EGFR testing showing EGFR wild type. Basically, looking at the options or the next steps, she has squamous cell carcinoma, stage 4, EGFR wild type. The standard would be platinum-based chemotherapy with pembrolizumab today. But since she is a non-smoker, the guidelines suggest comprehensive genomic profiling. Now we can choose either to re-biopsy or to take a liquid biopsy here. We decided to take a biopsy and completed comprehensive genomic profiling and found the patient to have a ROS1 fusion. Interestingly, as you see here in the report, we can find also STK11 mutation that is more related to pulmonary adenocarcinoma, and we can find an FGFR mutation, which is more prevalent in squamous cell carcinoma, and the whole picture suggests an adenosquamous histology with possibly a small biopsy not identifying the adeno component. The patient was treated with crizotinib. Today she would have received entrectinib, which is reimbursed in Israel since 2020 for ROS1 fusion, but at the time this was the only available treatment and responded very well, as you can see here. Another example is a man, heavy smoker, diagnosed with metastatic adenocarcinoma back in 2018. He had a hotspot testing for all targets known to be covered or reimbursed in Israel back at 2018, including EGFR, ALK, ROS1, and BRAF. They were all negative and the PD-L1 was high. So he was treated for several years with a standard care, first on a clinical trial with chemotherapy pembrolizumab for a long time, and then after progression he's had palliative radiotherapy and continued to another clinical trial with a cancer vaccine, then another standard chemotherapy, third line taxotere or docetaxel, until he exhausted all options after 2 years of treatment. At this point, we asked for a compassionate comprehensive genomic profiling test, and we luckily found a RET fusion. So RET fusions, we know today, can be found in less than 1% of all non-small cell lung cancer, mainly adenocarcinoma. It is much more common in papillary thyroid carcinoma. We have highly effective therapies for RET. These are selpercatinib and pralsetinib, which are specific RET inhibitors that are approved for this indication. But in this patient in early 2020, he was not eligible to go to the LOXO 292 clinical trial with one of the specific RET inhibitors, and there were no extended access programs in Israel, so we started him on another RET inhibitor, which is less selective, alectinib. Alectinib is an ALK inhibitor, but also inhibits RET. And the patient had a nice PR for about 6 months. Here is another example where comprehensive genomic profiling changed the outcomes. This is a female patient, never smoker, diagnosed with a rapidly progressive pulmonary adenocarcinoma with a large supraclavicular mass and a high burden of disease in lymph nodes all over the body, in bone, in adrenal, and also with asymptomatic brain metastasis. Because she was very symptomatic from a huge supraclavicular mass, the tissue was sent to a rapid hotspot testing, including EGFR, ALK, ROS1, and BRAF. All came back negative. By the time we saw her, she was already very symptomatic from this neck mass, and she had no tissue for comprehensive genomic profiling. The tissue was already exhausted. What should we do? So she was offered chemotherapy with pembrolizumab at another center, but we offered her to hold the treatment because she would likely not benefit from pembrolizumab and also has an active rheumatoid arthritis that might cause some damage or suffering from a rheumatoid arthritis flare. We sent her to receive radiotherapy for the symptomatic neck or supraclavicular mass, And at the same time, we sent her for a liquid biopsy comprehensive genomic profiling. And here is what we found on this liquid biopsy. She had a MET exon 14 skipping mutation. MET exon 14 skipping mutations are seen in 3 to 4% of adenocarcinoma and is in a much larger proportion of patients with sarcomatoid carcinoma. As you see here from a study, there is a high importance which test and which technology is being utilized when looking for MET, since not all skipping mutation and fusions start and end in exon 14 and thus can be missed in certain tests, especially tests that rely only on DNA. It is important to distinguish MET skipping mutation from MET fusions, which are also targetable, but also from MET amplification and MET overexpression, both of which are much more common but not targetable. There are 2 approved agents for MET exon 14 skipping mutation. Despite the fact that we have no randomized trials on these agents, and this is thanks to their activity. It is tepotinib and capmatinib. Historically, we can also use crizotinib, although we know that crizotinib has limited CNS penetration. Our patient went on capmatinib through an extended access program, and within a month, we had a complete metabolic response and a complete disappearance of her brain metastasis. This was a very rapid and deep response. Of course, symptomatically, she also improved. Now, there are many investigational uses of comprehensive genomic profiling and specifically to liquid biopsies. These include early detection of lung cancer in smokers through tumor DNA identified in blood. A diagnosis of the type of cancer can be done sometimes with unknown primary cancers. This can also be used to monitor response to therapy in patients according to the allele fraction, decrease or increase while the patients are receiving therapy, and more. I will briefly discuss 2 applications that are in research for comprehensive genomic profiling. One is the identification of resistant mechanism, especially in patients who are on TKI. And the other concept is the concept of minimal residual disease, which we will discuss now. So regarding resistance, this is an example of a 36-year-old physician, pediatrician, never smoker with a history of lymphoma in her childhood. She was diagnosed with ALK-rearranged non-small cell lung cancer metastatic to the brain and the bone. She started treatment with alectinib with marked response, including in the brain, but she experienced progression of the primary tumor in the lung. Normally, she would have only had radiotherapy to this progressing site, but she first had a bronchoscopy and a biopsy with comprehensive genomic profiling. Sequencing the new biopsy, we found high MET amplification in the tumor, and the patient is now on alectinib and tepotinib, a MET inhibitor with partial response, and no new events in the past year since she started this combination. There are some new prospective trials looking at the mechanism of resistance and tailoring a new targeted agent in combination with the old one, and it would be interesting to see the results of these clinical trials. Now, what is MRD, or minimal residual disease? MRD is a point post-definitive treatment, such as chemoradiotherapy or surgery, where clinically there is no active disease that we know about. Studies as this one show that patients who were treated for localized lung cancer and had undetectable ctDNA post-treatment had improved disease-specific survival. And these patients are all patients who had a baseline, or the majority of them had baseline detectable ctDNA or tumor DNA in the blood. This is applicable after chemoradiotherapy, but also after consolidation IO, as we use in stage 3 non-small cell lung cancer. Current studies are integrating ctDNA in decision process before randomization of patients, with the concept that in patients with resected non-small cell lung cancer and no circulating tumor DNA, they might not need any adjuvant treatment at all. Time will say if this is a true hypothesis. The main barrier is the limit of detection of these tests. There is a clear correlation between tumor size and tumor stage, and between its potential to shed DNA to the blood in detectable amounts. The more these tests would become sensitive, the closer we will be to using it at any decision point along the way for our patients. Going back to standard uses of comprehensive genomic profiling in lung cancer, I would like to summarize the 3 WH questions. Why, whom, and when do we use these tests? So why should we use comprehensive genomic profiling? Because it requires less tissue for a larger amount of genes to be tested, and not only the current genes that we are looking for, but also for future biomarkers, which today we don't know, but maybe in a year will have some meaning. The gene testing is done in parallel in a more sensitive method when we compare it to hotspot testing. Who should we test? We should test all patients with advanced non-small cell lung cancer, which is not squamous, and also atypical squamous cell carcinoma patients, meaning younger light smokers, or those with a mixed histology of very small biopsy. When should we conduct this testing? Preferably on diagnosis, and if not done on diagnosis, later is also okay. In patients with oncogen-addicted tumors on TKI who develop resistance, repeated comprehensive genomic profiling can identify the mechanism of resistance, which is sometimes a target by itself. Testing rates are far from ideal. Collaboration between medical oncology and pathology to design the best testing strategy for patients is highly encouraged. And with that, I would like to thank you for listening. I will be available for questions during the live panel. And I wish you all health and peace. Bye-bye.